But there is more to learn about the aorta. Here's a case of a 26-year-old music student from Finland that came to Vienna to learn music. She was found unconscious at home by her friend and was brought to the hospital with an ischemic insult, fairly large insult. What had happened? Well, we performed a TE study in this patient, and you can see the aorta, the ascending aorta. It looks quite normal. Now we're turning to the aortic arch. Do you see something abnormal here? Well, there is definitely no classic dissection here. There's not even a typical plaque we see. There's only one thing that looks somehow awkward, and that is the thickness of the aortic wall here. Well, this patient had the same appearance of the aorta with CT. You see that we have this awkward wall right here. And if we performed other imaging modalities, we actually found with a CT angio that the patient had occlusion of the left carotid artery. This obviously was the cause of stroke. But what is the reason? Why does such a young patient have a stroke and complete occlusion of the carotid artery? A very rare disease. She has Takayasu arteritis. Takayasu arteritis is a very rare disease. It only occurs in 0.1 per 100,000 population. It's more common in Asians and in females, and it is characterized, or it is actually a form of vasculitis which involves the intima, thereby causing fibrosis of the intima, and it occludes the large arteries, especially of the aorta, in this case, or in our patient, of the carotid artery. Now, this is a very rare disease, of course, but it again shows you what you can expect in the aorta. Our patient survived, but left the hospital severely disabled. Now, this case just highlights that the aorta is involved in stroke, but it is not the most common cause of stroke of the aorta. This is the most common cause. Those are massive atheromas of the aorta, which are more common than, of course, Takayasu disease. Now, let's turn first to the normal aorta and look at the wall. Here you see the short axis view of the aorta while we retract the probe, and the intima media here is actually not very thickened, it's normal. We have a very regular contour of the intima. This is not the case in this example here. You can see that we have an irregular surface, a very thick intima media. We've got plaques here in the aorta, and we see that in a long axis view, these plaques change in their configuration from cranial to distal. So those are plaques you will very frequently actually encounter in patients when you examine them, not only those who had a stroke. What should you actually look for if you have plaques? Well, first of all, at the thickness, at the composition, in other words, if you see calcified plaques or soft plaques, what the shape of the plaques are, if they're irregular, maybe you might even find thrombi on the plaques, and the complexity, the so-called aortic syndromes. We'll be talking more about that in this lecture. And then finally also the location, because you need to know if it could be a cause of stroke. Obviously, only plaques which are located in the ascending aorta and the aortic arch can cause stroke. In principle, we know that the morphology of the plaque and the size of the plaque are strongly related to the risk of developing stroke, especially in the ascending aorta. If you have a plaque which has more than 4 millimeters, then the risk is much, much higher versus those who only have a plaque below 4 millimeters. Of course, don't forget that the size of the plaque and the massiveness of plaque burden in the aorta is always somehow representative for the entire vascular system. And if you have them in the aorta, you can be quite sure you'll also have in the carotid arteries and probably also in the coronary arteries. What are the typical regions? Where will you find the plaque? Well, you'll find them not so frequently in the ascending aorta. If you find them there, it's usually in the aortic sinuses, close to the coronary arteries often. You would find them very frequently in the region where the big branches, the large branches, exit the aortic arch, and where the bloodstream kind of hits the aortic arch until it moves downwards towards the descending aorta. And then a very frequent location would also be in the cranial segments of the descending aorta. I want to now show you some examples so that you see the variation and extensiveness of plaques. Here is a long axis view, and what you see here is a plaque located in the aortic sinus here. Calcified plaque. Sometimes if you use a short axis view, you could nicely visualize the coronary arteries. Here would be the left coronary artery, and sometimes, as in this example, you would see a plaque here right at the ostium of the left coronary main. Now, of course, this is not comparable to angiography, but sometimes we can actually see flow acceleration with color Doppler as well, and thereby suggest that there is coronary flow obstruction. An example of a short axis view of the descending aorta. Now we're very close here to the left atrium, so we are the cranial part of the descending aorta, and you see that there are plaques here, 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 actually surrounding the entire circumference of the aorta. Now this is, I would say, still a moderate to extensive plaque, but it's relatively, I would say, smoothly contoured, but we see that there are areas inside which are more echogenic than others. So this would be basically a mixed plaque. In a long axis view, we see that there's a plaque which is almost obstructing the lumen, a very large plaque which is irregularly contoured. Now, this area here is echo-free, not because it is echolucent, but because we have shadowing. So actually the plaque is much larger than you can appreciate here in this long axis view. An example of an irregular plaque, very large as well. You see that there is actually an ulceration here. There's a little bit of calcification here, and the entire plaque is very rough and irregular. Those plaques would be considered complex plaques and thereby have a higher risk of, I would say, embolism, but also of rupture. Beautiful example of a plaque which is a little bit smaller, but if you look closely, you see that on this plaque, you have a very small mobile structure. Now, this might be part of the wall of the aorta, but sometimes also a thrombus. An example of a mobile structure seen in 3D here on the right, you see that this is a plaque, and on this plaque you have a mobile structure. Of course, this is something you don't want to have because you can imagine that there is certainly a risk that this embolizes as well. Another example of a very complex plaque. What do we see? We see that there is an irregular contour here, very thick plaque, definitely more than 4 millimeters, and there is an ulceration here, and on this image you can see that there's also a mobile structure. Again, a very complex plaque, and we know that these patients have a higher risk of embolism. Now, these examples actually bring us to the next very important topic, the topic of aortic syndromes. Aortic syndromes are one of the following three: penetrating ulcer, intramural hematoma, or localized dissection. We've seen examples of localized dissection in the previous section. Now, what is a penetrating ulcer? Basically, it is a disruption of the intima media by a plaque, and then you have kind of a cavity that forms. And from this cavity, a number of different things can happen. Either you develop intramural hematoma, in other words, it bleeds into the wall of the aorta and causes a hematoma within the wall, or you could even have local dissection or disruption, as you will see later. Here is such an example. On the left-hand side, you see a massive plaque in the aorta. Right here, you see that there's even a mobile structure, and then you have these ulcerations here. And if you turn and twist the probe a little bit, you will see that all of a sudden you have this echo-free space here within the plaque, where there is the suspicion that there's blood flow actually in, and that this is actually hematoma. You see that the whole aorta seems to be wider here. So this would be a patient who probably has an intramural hematoma. Now, echocardiography is not the ideal technique to really look at this. Probably better to use other imaging modalities, but we can definitely make the suspicion that this is the case in this patient. So, as mentioned, you could have an ulcerated plaque where it bleeds into the wall, and then we could have complete perforation and also bleeding outside of the aorta, in other words, aortic perforation. So in this case, the very same problem as with the aortic dissection. We can have acute problems and the patients can even die. Of course, if the hematoma drains, then we would have a localized dissection. This is probably one of the causes you have this localized dissection, and not infrequently you would then have dissection going on from there to the remaining parts of the aorta. In other words, there's kind of an overlap between aortic syndromes and classic dissection. Sometimes we have a thrombus in the aorta, and it's very difficult to say if it is an intramural bleeding or if it is some kind of thrombosed false lumen. Let's take a look at some examples. This is a patient where we see that there is a mass, a thrombus right here, and where we cannot say for sure whether or not this was maybe a localized dissection, which thrombosed, or maybe it's intraluminal hematoma. What are some of the facts about these aortic syndromes? So first of all, intramural hematoma has a little bit a better favorable prognosis than acute dissection. It doesn't always lead to rupture. Second of all, intramural hematoma and ulcerations have a worse prognosis if they're located in the ascending aorta, very similar as dissections. And the risk is associated with the diameter of the aorta. So if you have an aortic diameter which is above 50 and an intramural hematoma, the risk of rupture is much higher. It depends also on the presence of symptoms. If patients have pain, then that would denote that they're at higher risk. There's something going on in the aortic wall. And then finally, it's the depth of the ulceration which seems to also play a role. Okay, two more things. This is an example of a patient that we imaged who had obstruction of the peripheral arteries, embolization into the peripheral arteries, and the reason was this. We actually found a fairly large mobile thrombus which was attached to the left subclavian artery, which protruded into the aortic wall. So this is something which is sometimes very unexpected, but you can also find in the aorta. And finally, another issue that you see off and on is the so-called slow flow phenomena in the aorta. In such patients, you can actually see the blood flow moving in the aorta. Why does that occur? Well, one factor is certainly low cardiac output, in other words, patients who have poor left ventricular function, but even more important is probably the vascular resistance. If patients have very high blood pressure and the periphery is kind of, I would say, atherosclerically obstructed, then you would see this phenomena where you see actually the blood flowing. Now, this is certainly something you do not want to have, and we know that these patients are at very high risk of stroke. So keep that in mind when you look at the aorta. And sometimes these findings can be very dramatic, as in this case, now you have the impression that the entire aorta is going to thrombose pretty soon. Good. So I think we are finished with this chapter on the aorta. You see it's a very complex issue, but a very important one. And I can only emphasize, if you have a patient where you perform a TE, always look in the aorta. Sometimes you need to look because you have a pathology you're looking for, but very frequently you will have an incidental finding.